with the right kind of feedback and change. And I'd like to welcome our guest now. Dr. Mary Coan is here, lead of the Patient Survey Project, a steering committee member for the Patient Clinician Alliance, physician in private practice, practicing integrative medicine. Dr. Coan, welcome. Thank you for being on the program today.
Thank you.
Next to Dr. Coan is Joel Elliott, who's a steering committee member for the Patient Clinician Alliance. Joel, thank you for being here.
Thank you, Evan.
And welcome to Dr. Michael Privatera, who's a founding member and steering committee member of the Patient Clinician Alliance. Thank you for making time, Doctor.
Thank you, Evan.
And so we're going to talk about the survey in just a second. In fact, you can learn more about the Patient Clinician Alliance at patientclinicianalliance.com. We'll have links in our show notes if you want to check out a lot more here or do the survey. There's a lot here. Listeners, we want to hear from you this hour. I want to hear what has worked well, perhaps, in your recent experience with the medical system, or maybe what has not. And that could be a million different things. I mean, everyone has to deal with the system at some point. Maybe you're caring for yourself or a loved one or a parent or an aging parent, that kind of a thing. But we want to know what's working. And I'm going to go around the table. I'm going to start with Dr. Coan and just tell us a little bit about why the survey has come to be and why this alliance has happened. And frankly, if realistically you think change is possible, Doctor.
I like to think change is possible. I do have my doubts about that. I became very interested in doing the patient survey when Dr. Privatera did the physician survey, because in my mind, our focus on changing the healthcare system shouldn't really be on the physician. I think the focus needs to be on the patient. The patients are the ones who are shortchanged with the problems that we have in our healthcare system. If there's anything that I can do to get my patient's voice and any other patient's voice heard, I want to do it. So that's how the patient survey came about. I talked to Michael and we like, yeah, let's do a patient survey.
Okay. Dr. Privatera, are you confident that the system can change?
It's got a lot of change to occur to be better. I'm still hopeful. I think we've put together a mechanism that it can little by little improve. And if the kind of structures that we suggest go into place with our Patient Clinician Alliance, with plenty of feedback systems from people that use the system, and that can get to executives who make decisions about resources, we think gradually it can improve. So that's why we think a structural change is important to help that.
Before I turn to Joel, who's really representing patients here. Oh, go ahead, Dr. Coan, yeah?
And if we don't try for change, we won't get change.
Well, I mean, that I think is undeniably true.
Right.
And inertia is powerful.
Right.
But I'm reading what Dr. Privatera told WHEC. You said, I never used to think about retiring, but it was the system that made me say, I can't do this anymore.
Yes.
That is tough to hear.
Yeah.
And I'm sure you've got patients who've developed relationships who love you, and that's hard to hear. Doctor saying, I don't know if I can do this, and I'm sure you're not alone. Why are you at that? Why did you get to that point?
Well, it was the issues of what you need to do that kind of stand in the way of your routine of trying to help patients, what you got trained to do, and how the system, the hoops you have to jump through, kind of just wears you out, and it does demoralize. And I think it goes just to the opening statements you made. And I worked until I was 70, so I kept trying. I had to diminish hours, but definitely I was part of people's lives for years. I practiced for 43 years. I miss them. I miss the people. I miss the people I worked with, but just couldn't keep up what was expected of me, and aging kind of worked in the other direction. So I had to stop. So.
And it was Dr. Coan told WHEC, you said, I'm board certified in both integrative medicine and family medicine. It gets harder every single day, and I think we've definitely come to a healthcare crisis that's beyond the individual patient, the individual physician. It's a whole community crisis. How did we get here?
Honestly, I just was at a meeting with Rochester Regional where we went over all the new metrics we need to meet, all the new check boxes we need to complete. And I actually raised my hand and I said, we've been doing this for 5 years. Every year there's more requirements, more metrics. Can you comment on whether or not this has improved patient outcomes? And the speaker was silent for 20 seconds and said, valid. silent another 20 seconds, and went right back into it. We spend an inordinate amount of time checking boxes, meeting metrics, and it's not changing patient outcomes. That's a problem. After the talk, I spoke with this gentleman, and he's like, this is coming from CMS. And my opinion is, why can't the large systems go to CMS and say, this is failing? We need something better.
But doctor, what's an example of the metrics that you, because metrics, first of all, is a very sort of nebulous corporate-y word that doesn't really feel at first glance like it has a place for telling doctors how they should be doing their work with patients. However, if the metric is, every year we're going to survey patients and we're going to see how their experience is, and we need to, 90% need to be satisfied, or we need to, whatever the case is, versus something that is a little more bottom line driven or something a little bit more volume over quality. So what are the kinds of metrics we're talking about?
So the metrics are largely based in value-based care. That's like a new buzz phrase for how we're supposed to do healthcare. So if I don't order mammograms on every single one of my patients, I fail a metric. If I don't have hemoglobin A1Cs below 8 on my diabetics, I fail a metric. If my patient doesn't want to do some of these things, there's no way for me to defend that my patient doesn't want to do these things. So it's lots of metrics like that. Make sure you get your mammogram, make sure you get your bone density, make sure you get your PSA, make sure you get all of these things that are supposed to improve the value of current healthcare, which is why I had asked that question. Have we improved patient outcomes? No, we haven't. So we're just adding more checkboxes for doctors based on CMS's view of what things are going to improve patient outcomes, but they're not improving patient outcomes.
So Joel Elliott is a steering committee member for the Patient Clinician Alliance. I want you to describe a little bit, and let me also say, Mary Jo from Rochester, I'll take your call in a second. We already have some feedback from listeners who want to talk about their experiences in the system. So I'll take it in just a second. Joel, tell us a little bit about what the Alliance is, why it is happening at all here, and, optimally, what may come out of it here.
Sure. About 5 years ago, there were 8 or 10 of us, many physicians, others just interested people. I was working at St. Joseph's Neighborhood Center, which is a comprehensive healthcare center for folks that don't have access to insurance. And so it meets a special need in the city. And so I was very aware that there were people falling in between many cracks in the system. And then COVID hit. At the same time, this 8 or 10 of us were talking, getting together once a month and just talking online on Zoom about how healthcare could be improved. What were some of the structural barriers? And we came across this wonderful organization, X for Health, that was doing a study. They were bringing together 6 physicians or other clinicians, which could be nurses, nurse practitioners, dentists, counselors, therapists, and 6 patients. And of course, realizing that all of the medical providers are also patients and have their own experiences, and doing a 3-hour conversation, which was guided by a facilitator. Well, we did 6 of those, and we did those at Jordan Health, at the Finger Lakes Community Health, at Unity, at Strong, and we found that there was something of value there. That was 2021. Ever since then, we've been trying to figure out a way to make that a more ongoing process where the same 12 people, 6 clinicians, 6 patients would get together, talk about issues of the day, just like your listeners are about to talk with us about, and then take that information and turn it around and get it on an outward-facing stream of communication, whether that's a website, whether that's journal articles, etc. So that's how it started and where we've come to.
And you want 1,000 participants?
For the survey?
For the survey.
1,000. We have 700 now. We wouldn't mind a couple thousand.
Okay, sure.
And, widely across the area.
The cynical part of me, that is not a healthy thing. Cynicism is not very healthy. Whenever I talk healthcare, the cynical part of me is like, I'm taking over my brain. And it wants to say, it's just adorable that you think this is going to change anything. You know, just how noble of you to think that a survey is going to show people what's wrong with, or, you know, haven't they been talking for decades? But then the optimistic part of me says, this is what we need. We need ongoing conversation that says we understand inertia is powerful, but if there is consensus on issues that have to change, sometimes you got to beat it into the system.
And maybe look at it a little differently too. Yes, be cynical, but patients are cynical with other patients. Physicians are cynical with other physicians. Just get these two talking and you'll see. But they never sit down and talk about how their situation it feels and what are the barriers. Mike's very humble. He won't tell you this, but he was responsible for the wellness committee or group at the University of Rochester for many years. And so he really understands. The only thing I'll say is, listen, the payers, insurance companies, government officials, hospital system administrators, they all have hard jobs. But to put patients and clinicians at the center of this and then get information to them might be a little bit helpful. And then maybe we'll all be a little less cynical.
No, I mean, I actually think there's a big difference between cynicism and realism. Cynicism prevents change because you become a nihilist. Realism recognizes how hard it is, but is still determined to overcome those barriers. So I try to not be a cynical person, though there are times where I'll say to like Megan, like, am I being cynical or realistic? She's like, well, you're being a little cynical here. So I think this is a realistic effort. I will say, Joel, I mean, why not be optimistic about it?
Yeah, and realism sometimes has some negative aspects, and certainly the healthcare system in America is probably neither healthy nor a system. So there you go.
Let me just take a couple phone calls quick here, and then we're going to get into what the survey is asking people, and maybe some of what we might learn from this. But right away, Mary Jo called and has been waiting. So hi, Mary Jo, you're up first.
Good afternoon. I'm going to try not to be cynical. I called my doctor's office this morning after several days of having swollen legs and swollen feet, and they don't seem any better in the morning. So I thought, well, I'm going to give them a call. So I called, and at first I tried to make an appointment online, and I couldn't get through. So I called, and they said the soonest they could see me would be July 25th, or they would have a nurse call back in the next 4 or 5 days. So I want to know where I go from there, or I could go to urgent care, which I've been told before. So what do I do?
All right, let's hang there, Mary Jo. Who wants to
Okay.
start here? They're all pointing
They're all
to Dr.
pointing
Mary
at me.
Cohen.
Yes, this is a huge problem. Some of the changes that have happened in the effort to, quote, improve healthcare are that now when you call, you get a central line. Often you don't even get your physician's office. To see a physician is getting harder and harder and harder. Most likely, you're going to be seeing a nurse practitioner or a physician assistant, and they're all overworked. They're all scrambling. It's not that they don't want to take care of you. I think if you were to ask your doctor personally or ask if they have mid-levels working with them, they of course want to take care of you. This is one of the reasons that we argue that the system is failing. If we had the old-fashioned, even 20 years ago, you would call your doctor's office and speak to the secretary at your doctor's office, and somebody would talk to somebody, and they would fit you in. That doesn't happen anymore.
Okay.
Anything to add there, Dr. Privatera? Go
just
ahead.
That these are kind of side effects of what's happening in the system, why it's harder and harder to get in, just as Mary just pointed out. I think drawing back to the physician survey we in 2023, which was only 2 years ago, almost 30% of the physicians we surveyed described that they wanted to, were either likely or very likely to retire in the next year, and 45% described that they needed to cut back their hours. So going through this much education and training, you want to be able to give good care, but it's just a sign of the demoralization and the resistance to be able to do what you need to do. That just where is the human a part of that equation that gets worn down. So that's why we kind of revitalized the idea of the Patient-Clinician Alliance, and why it kind of helps politically neutralize what kind of concepts we come forward and we want to recommend, because it's coming from both patients and clinicians. That's different from anything that we've done before. The fact that the kind of metrics that we're coming up with will count how many times the same problem is coming in from the community, how many times the same complaints are coming in, and to see if there's any connection with certain zip codes, for example. So there's a kind of a scientific way that we're trying to accumulate information that then filters upwards to people that make decisions, and also gets onto the website to externally to the community, that everybody can see what the data is.
And we would love you to do our survey.
Yes.
And Joel Elliott, go ahead.
The only thing I'll add is that I hope that you are feeling better soon and that you find a way to get the care you need.
Mary Jo, I don't know if that's exactly what we're looking for. It's a hard problem to solve. Anything you want to add?
No, I'm perfectly happy seeing a nurse practitioner. I told them that, but they just can't fit me in, and I know it's a problem. I can't blame them. There's too many people and not enough doctors. So I thought it was just a good chance to get my opinion out there and see what you thought. I will fill out the survey.
Thank you.
Thank you very much.
Thank you, Mary Jo. I appreciate that. We're going to get into the survey in just a second. I got to clear some phone calls off the board because Rochesterians are not the whole region is responding to this issue. Courtney in Rochester next. Hi, Courtney. Go ahead.
Hi there, Evan. Can you hear me?
I can. Go ahead.
Okay, wonderful. I wanted to speak about the issue of chronic illness and disability and dealing with the healthcare system. Evan, I was on the show with you. I think it was last year.
Oh, yes, Courtney. Yes. Yeah.
Right.
I remember.
I facilitate a support group. As a matter of fact, we have a gathering this evening at 7 o'clock for folks dealing with chronic illness and disability. And one of the things that we frequently talk about is, the experience that we have had either going to a doctor's appointment or trying to schedule a doctor's appointment. And the difficulty there is that when you're dealing with a chronic illness, especially if there's something that has yet to be diagnosed, being referred to a specialist is essentially a waiting game. And while you're waiting, you're getting sicker to the point where you're so far gone down the hill that the likelihood of recovery is quickly moving towards zero. I was recently waiting for a referral and was initially told that the wait to see a particular doctor was 3 years, and which is not at this point really uncommon when we discuss these things within the support group. I'm hearing back from people saying it's 6 months to see this specialist, or it's 6 months to see that specialist, or I'm flying to Texas, I'm flying to Virginia, of course, and that's if you have the finances to be able to do that. Of course, not everybody can hop on a plane and go somewhere else to see a physician within the calendar year. And so these are the kinds of issues that we've been dealing with. And the problem with that is, again, you want to be a fully participating member of the community. You want to be well. And the unfortunate thing is that you're kept in limbo because you can't see a doctor. And then to add insult to injury is you finally get to see that doctor who then says, well, I need to refer you to this person. And now you've got another 3, 6 months, maybe a year wait. And so you're just constantly waiting. And you want to talk about demoralizing, you want to talk about depression, and unfortunately talk about rates of suicide with people who are chronically ill, because they've gotten so ill, they're not getting any help. They're not getting any help in a timely manner. And that's something that really needs to change within the healthcare system, is how do we treat people who are chronically ill or as of yet undiagnosed? How can we get people better faster instead of really just warehousing people to the point where we just become sicker and sicker and sicker because we haven't received any care, or worse yet, we haven't even received a diagnosis.
Courtney, thank you. I mean, this is, first of all, thank you. It's great to hear from you, and thank you for sharing that perspective. Is this a problem that can be solved in the current system, or is this an issue of just personnel, number of doctors, number of people in the system? I mean, how do you start to solve this? Dr. Cohen, you want to start?
I think some of the burdens and metrics that I talk about play into this. You can stay, lots of physicians would see an extra patient at lunchtime, or see an extra patient at the end of the day, or see another patient at the start of the day. But I see patients all day, and I go home and eat dinner and get on the computer, and I'm on the computer for another 4 hours. So the idea...
Responding to patients?
No, doing chart notes, making sure
Okay.
everything meets all the rules.
Okay, yep.
And I do respond to patients too, and I do all my own labs, my own documents, all of that stuff, because I'm a little bit, that way. And so some of our ability to be flexible and try and get people in so they can be seen is taken away by all the requirements of the systems to practice according to the rules. Something I do for my patients is I actually talk to the specialists who have the long wait lists, and I say, what would you order? What tests would you do? What would be the first steps you would take in assessing this patient? And then I do them. Then I call that specialist back and I say, now what do I do? That's extra time that that doesn't count as credit for us in meeting our metrics. And it doesn't help you see the actual specialist, but hopefully it helps us get closer to at least starting a workup that might be beneficial for you.
Well, I mean, that's a creative way to try to start solving a major, major problem. But
Takes
let
time.
me ask your co-panelists then, hearing what Dr. Cohen is saying, is the goal of this survey, noble as it is, ultimately going to fail because the system is just broken? Or can the current American system dramatically improve without a systemic change, Dr. Privatera?
Without a systemic change, I believe the answer is no. The purpose of the survey is a product of the Patient Clinician Alliance. So the Patient Clinician Alliance system that we're trying to help promote and get into practice in our community is one major thing that we're trying to do. But the survey is one piece of data that we want to try to get so that it helps legitimize what we're doing. Because we have data from physicians, then we want to have data from patients and say, hey, look at the similarities here. And once you have data, you can get this to people that make decisions. Too much, we think, in the system is executive to executive discussions, not enough from people that are using the system, patients to executives, clinicians to executives. That's what we're trying to put in as the users of the system need to have more voice amplified. And that's the design of the PCA and once it's in operation. The survey itself is hopefully helping to legitimize what it is we're doing.
Joel, when you hear Courtney's story, and again, that's probably the kind of thing you've heard a lot of doing this kind of work, do you think we can dramatically improve this based on the feedback we're getting and based on changes that are achievable in the current system, or absent a new system, this is going to be a problem in perpetuity?
Well, if it's systemic change or incremental change that allows doctors and nurse practitioners and other advanced care professionals to do their job, I think that there is opportunity for change. One of the guys that was in one of the people that was in the study group with us is a very bright physician named Dr. George Anstad. And Dr. Anstad said, chronic illness is just illness that the healthcare system, that doctors haven't figured out how to cure yet. But if you think about the cures and the changes in technology, my wife last year had a hip replaced that used to be very difficult surgery. She did it. She was in the hospital for 24 hours. She was home and walking in 2 days. To see technology or treatments, CRISPR treatments, go from revolutionary to typical to almost mundane is progress moving forward.
I think that's fair. Yeah.
But illuminating the voices of patients and clinicians, the two parties that should have the loudest voice but actually have the softest voice in the system, is something that's possible. Whether that's going to impact change without, Harry Truman tried to nationalize healthcare. He was unsuccessful. And ever since then, there have been incremental changes. Some have been successful, some not. All we can do with the survey, with this process that Dr. Privatera developed, is try and illuminate situations like the one Courtney called in with.
Courtney, thank you for that. And by the way, this survey takes 10 to 15 minutes maybe. As Joel mentioned, they've had 700 people do it. They'd love thousands, and we're going to link to it in our show notes. We'll make sure that you've got a chance to take it if you want to do that. It's open through the summer, I believe. Is that right?
Yes.
And so they would love your participation. If you're on the phone, and that is Shirley and Brian and Pat, we're taking all your calls. We have to get our only break in, but you're part of the survey now, team. So we're going to get right back to your phone calls on the other side of our only break.
Support for your public radio station comes from our members and from United Way of Greater Rochester and the Finger Lakes, serving the community for more than 100 years, dedicated to creating a future where everyone's basic needs are met so all can thrive. More at unitedwayrocflx.org. And Bob Johnson Auto Group, proud supporter of Connections with Evan Dawson, believing an informed public makes for a stronger community. BobJohnsonAutoGroup.com.
This is Connections. I'm Evan Dawson. One other quick note before we get back to your phone calls, and I don't mean to editorialize too much, but if you have ever been frustrated with the American healthcare system, if you felt like, I don't understand this bill, or why do I not know how much it's going to cost, or why is this not covered, or can I get anybody on the phone? Can anybody get back to me? I can relate. And, we've talked a lot about things like producer Megan Mack's cancer 4 years ago and some of what became the basis for almost a comedy show for some of the things that she was told by people within the system, probably who are doing their best. But that's why this survey exists. That's why this alliance, the Patient Clinician Alliance, exists. And I'm grateful that they're trying. I am. So that this is the really optimistic side of it. And Dr. Cohen was saying during our brief break that, look, if we're all just going to be nihilistic about it, then we sure can guarantee that nothing will change, right? How would you put it?
Correct. That's exactly how I'd put it. And, maybe we make a change in Rochester. Years ago, Rochester was seen as the best healthcare community. Rochester General and Strong, docs talked with each other. There wasn't a financial, no, we can't tell you anything because you're the other system. If we can make something change here, maybe it'll be like it was years ago. We'll be a model of how to do healthcare better, how to care for our patients, have doctors not want to retire.
I'm very much on board with making that change. Here is Shirley in Rochester on the phone next. Hey, Shirley, go ahead.
Hi, can you hear me all right?
I can.
Okay, great. I was going to hang up because Courtney kind of covered what I was going to say. I was recently diagnosed with a condition that has a pretty strong correlation with melanoma, skin cancer. That was back in May, so I tried to reach a dermatologist, one that I've seen in the past, and I was told that I can't be seen until August. And it didn't help that I wanted to see a black dermatologist. By that point, I was ready to see any dermatologist, but not until August. And that's just crazy for someone who's got some real concerns about the progress of the condition. Why don't you say?
Yeah, Shirley, thank you for that phone call. I'm going to make Dr. Privatera start with this one. Can't make Dr. Cohen do it all. Go ahead.
That's right. Even though I'm retired, I'll
There
try.
you go, Mike.
For something like that, I know some systems of dermatology will have you take a picture of it, send it in so that they can have a triage system, so more rapid a view. If it might be cancerous, and they, by looking at it in the picture, they think so. They can try to get you in sooner. I don't know what systems you're working with on that, but that's definitely something that should move faster. Try the one system or the other.
Okay. Anything to add over here? That cover it pretty well?
So insurance often doesn't allow you to try one system or the other now. It depends on your insurance. You're told where to go for laboratory work. You're told where to go for your specialists. So you're sort of stuck with whatever system you're in. I don't know. If you
That's
have
where
a
you wanted the systems to work together better, it seems like.
Yeah,
Yeah.
absolutely.
This feuding
Absolutely.
between the two is just making things worse.
It is.
Not great for patient outcomes, I would think, Joel.
No, I'm going to make one suggestion. There is a Black Physicians Network in town, and they have an email address and a website. And I understand your concern of seeing a dermatologist who understands your particular issues and concerns and problems. So I'm not saying that it would help, and I certainly can't give advice on this show, but try and shoot them an email message and just ask if there's a solution.
Okay. And Brian wrote in to respond to Mary Jo earlier, who called in and was given a lengthy wait for a visit with her doctor. Brian says she may benefit from calling the office first thing in the morning and asking for a same-day acute visit. Most primary care offices block out visit slots that cannot be filled prior to that day to allow at least some access for more urgent medical needs. Often there are only several per office, and they can be filled quickly, so call early. Dr. Cohen, does that make sense to you?
That does make sense. I keep acutes open.
Okay. So good advice, Brian, and that's generous of you to call in and offer to help Mary Jo there. Good luck to you. And Shirley, thank you. Great to hear from you as always. Pat from Spencerport next on the phone. Hey, Pat, go ahead.
Hi, this is reference to, you talk about the metrics. So I went to just for a yearly physical with my physician. She said, did you have your DEXA scan? I said, no, I've never had a DEXA scan. Sent me, I have osteoporosis. Okay, referred to an endocrinologist. They prescribed a medication. My copay is $800 a month. I said, I don't think I can afford that. Is there an alternative medication? So they prescribed a different medication, and I just got turned down from my insurance. They denied that. So we'll just hope that I don't fall and break a hip. But a lot of the issues that people talk about, couldn't they be resolved if there were more medical schools in the United States? I've met several people who have applied to medical schools multiple times. Their SAT scores blew me away. I'm talking about like near perfect SAT scores. Intelligent, took all the AP classes, denied medical school admittance. So is there an issue with, and I'm sure it's not cheap, that's probably the issue, but if there were more medical schools, there'd be more providers, and then people wouldn't have to wait a year to see a specialist. There, I just solved the
You solved it, Pat. Dr. Privatera's got his hand up. Go ahead.
Yeah, just that's an important idea. It's kind of yes and, okay, to think of, yes, we need more incoming doctors in the pipeline, but if you don't change the system, you're just going to wear them out. So we're not solving the problem that once they get there, and then diminishing experiences once you're there. We have to solve both. So that's why we just wanted to say yes and.
Okay. Anything to add over here?
I think Mike said it. If you think about somebody that's in higher education for 14 years learning to do their work, and then the 15th year they're in a situation that burns them out, that upsets them, that drives them down, even changing the system enough so that they want to work an extra 3 years would take some of the burden off. So it's really the structural and institutional changes that need to happen. Having more providers step into a system that's largely broken is not a solution.
And the elephant in the room is the cost of the drugs, right? Why do pharmaceutical companies get to have such unbelievable profit margins. Why isn't the pharmaceutical industry regulated? Why isn't the insurance company regulated? You're paying a hell of a lot of money for insurance that then doesn't give you the drugs you need.
But let me ask you a serious question about that. The president recently said he's going to just make sure that drug prices can't be that high anymore.
That would be great. There's a lot of lobbying out there, pharmaceutical lobbying. I believe last time I looked, there's more money in pharmaceutical lobbying than in any other field.
Lobbying and advertising. Advertising that you see on the TV, if we do this, it's good for everyone. Not necessarily has that been the case. I think the point being of how to improve things for the individuals coming forward. So that's all.
I wish both of those industries were regulated.
Yeah.
Insurance and pharmaceutical.
Okay. Let me get back to the phones, and this is Brian in Spencerport. Hey, Brian, go ahead.
Perfect lead into my point, which is I did Google. See, I've got this terrible memory. I remember stuff. And I remember back in the 1980s, the AMA went all out to reduce the number of doctors because they felt that the doctors weren't being paid enough. So they went and all the medical schools reduced the number of graduates that they would have, and we're experiencing it now. I'm sure if you Google 1980 AMA reducing doctor seats in medical schools, you'll come up with that. Because I've done it. Because I thought maybe I was wrong, so I Googled it, and it happened.
So the AMA represents a very small percentage of physicians in this country.
And a very powerful one back in the 1980s.
Correct. Yes. And most of the funding for the AMA comes from the pharmaceutical industry.
And there you go. Maybe that's why we don't have enough doctors today, because in the 1980s the number of graduates was dramatically held back.
Yeah. Yeah, some of the things that the AMA did, I don't necessarily agree with. They're not saints. I don't think that all the best intentions were there years ago. I left the AMA for some of those reasons for a while, and I only joined back once I saw that they were working for what seemed to be a better condition for everybody.
Interesting. Go ahead, Joel.
You know, the Monroe County Medical Society has been around 203 years. And when I learned that, when we started working with them, with the Patient Clinician Alliance, I thought, gosh, 200 years ago, what was a medical society about? And obviously, the needs of the members of the society, and there are about 900 members in town, in the area, have changed. And so they've tried to pivot toward community health. And we really are encouraged by all of the projects that they have going, and I became familiar with them because of Dr. Privatera and Dr. Cohen and the committees they chaired. So there's good work that can be done since the 1980s to now, and maybe in the future as well.
Brian, thank you. Before I get back to your phone calls, let me hit some of the email at connections@wxxi.org. Tim said, I'm interested in your guests' opinions on two topics in the healthcare system. The first is the role of loneliness, depression, anxiety, drug and alcohol abuse driving up overutilization of healthcare. Dr. Cohen?
Uh-oh. I was just pointing at Dr. Privatera.
Okay. Dr. Privatera.
Well, yes, and some of the studies in certain systems, even like in orthopedics, using the PROMIS system where you do depression ratings to see how that correlates with outcomes. Definitely a major factor. It affects the outcome of heart disease, hypertension, cancer. So depression definitely is a major factor in outcome. And whether it drives up costs, maybe it does, certainly for diabetes too, because when you're not motivated and don't have drive, energy, and motivation, you're not taking care of yourself as well, not keeping up with your insulin as much, your diet. So that drives up costs. So yeah, it's a major, at least depression. Loneliness, don't know the answers on that one, but certainly that's a health issue that the Surgeon General brought to our attention. Is loneliness is a very big issue about our health.
And you can all jump in if on the second from Tim. He says, is private equity purchasing up practices, is that helping or hurting the system? Private equity in the system.
No.
I think it's actually hurting the system. However, I have to tell you, I work for MDVIP, which is a private equity company. The reason is I'd like to give my patients more time than I was ever allowed in the system. And so in terms of my goal being getting better health care for patients,
You felt like you had to go there?
I felt like I had to
So
go there.
kind of like an imperfect solution that you saw?
Yes.
Okay, fair. Joel?
Yeah, with just the conversation that your listeners have brought to us, you can hear all the workarounds that doctors have to employ to serve their patients. And so it becomes this amazing maze of working around. We haven't even talked about prior approvals, which is the concern that I hear about so often from providers, from doctors. To get what their patient needs, they have to jump through many hoops and wait 2 weeks, 4 weeks, 6 weeks. But it just seems that the workarounds slow them down rather than helping to get to patient care.
There was one study in the journal American Medical Association about private equity that in the first, say, 3 to 6 years, it seemed to be helpful, and after that, it seems to be extracting capital from the systems as a means of making money. So initially looks good, and then gets worse.
And then a different Tim wrote in to ask about if we're going to see Medicaid coverage and coverage dropping for Americans with the new budget. Listeners, if you've been listening to Connections all afternoon, which you should, you might have missed that at 12:30 this afternoon, in a 50-50 vote, the vice president cast the tie-breaking vote. So 3 Republicans in the U.S. Senate voted against the budget bill, and so it was a 50-50 deadlock. J.D. Vance, the vice president, broke the deadlock. The bill passed. It will go to the president, and he will sign it. And a second, Tim is asking, does this mean less Medicaid and less coverage? Anything that we know about that? I don't. Any concern about that?
I would imagine that would decrease coverage, but I don't have
Devil's in the
statistics.
details? Okay.
Yeah.
Devil's in the details. Okay.
Yeah,
Yeah,
same.
that's breaking news there. So, Tim, sorry we couldn't get a little more information. We'll talk more about that in the future, I am sure. Let's get back to your phone calls and Jane in Rochester. Hello, Jane. Go ahead.
Evan, J.D. Vance, is he ever going to go away? I never forget the cat lady thing. But not my favorite person. But months ago, maybe a year now, there was an investigation that was aired by PBS, and it's on the subject of the AMA and what it contributes to the shortage of specialist doctors, but especially specialists. And it's been a while, I don't remember all the details, but it had something to do with if there were fewer doctors, you know, they're not easy to get because there's so few. Somehow they could charge more, you know, because, you know, we have to really work to find you a doctor. It's an attitude that they're selling. But it was on PBS, and it was just riveting and sickening because you could have more doctors, but the AMA stands in the way, and it had to do with money. So I don't know the title of that program to give you or anybody else, but it was really educational. So some of these problems can be solved, except for the ugly head of money coming in and influencing it differently. But anyway, I'm enjoying your program very, very much.
Jane, it's always nice to hear from you. I can answer your first question. The vice president will be the vice president for this term, and then he will not be the vice president, but he may be the president next after that. We'll see. There's a lot that could happen. So you may have to get used to J.D. Vance, Jane, even if you don't like him. But for now, he is casting the tie-breaking vote today. And the second part of your point there, you know, I guess I'll turn it over to the panel. Anything you want to add to Jane's points, observations about the system there, Dr. Privatera?
No, she encapsulated things pretty well, I think.
Okay,
Yeah.
fair enough.
I just think that the pharmaceutical industries have a lot of influence over the AMA as well.
Okay. Jane, thank you. Gary in Bloomfield is next. Hey, Gary, go ahead.
Well, thank you very much. Yeah, actually, it's good that I'm following up with the last few comments. First, I wanted to expand the problem. It's not just the medical field. it's the whole industrial takeover of everything American. When profits have become the sole driver of everything, that's causing the problems. There were many, and you also had a history. A guy went back to the Reagan administration before me, and before Reagan, you weren't allowed. The problem was the insurance companies. You weren't allowed to advertise medicine on the TV and stuff because of what had happened. People come in and they give, they think they found the cure, which of course has not been found, and then they're insisting on their doctors prescribing it, even though it's not the right medication for them. There's a whole bunch of stuff. I think the argument the solution is to actually look at the entire corporate system, and everybody on the show has been talking about how money has been the corrupting influence. And unless we deal with a system that says that the only thing that's important is to make profits for the shareholders, we will not, and get money out of politics, we will not be able to cure any of these problems.
Well, I appreciate the phone call and the concern. Gary, I'll let our guests maybe not only respond to that, maybe offer some final thoughts in our last couple of minutes. I will say, Gary, the TV is not on that much in my house, and my son was 7, 8 years old when he could sing the Jardiance song and these different pills. And Jardiance is really swell. It's a little pill with a big story to tell. I've heard that a million times, and that little jingle. And I don't know if that's a good thing or a bad thing. I think, but they're probably helping a lot of people. Pharma's probably created a lot of things. To Joel's point earlier about innovation in medicine has come a long way. And if we went back 100 years, people would probably say, what are you all complaining about? It's amazing. But you also understand Gary's point there, Joel. And so how do you split the difference? What do you make of Gary's point?
Well, I'm going to say that we have the best health care in the world in the United States, but what we don't have is access to it. And so there are neighborhoods that don't have access to health care. They're deserts, they're healthcare deserts. There are individuals that don't have access to health care because of their insurance, small business people that can't afford the most expensive kinds of health insurance. So having the best in the world but not giving access to it maybe is that profit motive. Who knows what all the elements are that create it, but what we really need to do is focus on having good health care for everyone.
Well, and Dr. Cohen, maybe that's a good place to end with you. I know inequity in healthcare is a big concern of yours. What do you want to leave with listeners?
So one of the things is that we would love any volunteer help with getting our survey out to underserved populations, because most of the survey results that we've gotten now seem to be skewed. And we would really like to have a better view of what's happening in the entire greater Rochester area. So anybody who has ideas about how to help us get our survey out, even if it's just telling people to go to the NPR site and taking a picture of the QR code and doing the survey that way, any way that we can get help with getting the survey out there, in the hopes that, yes, we can make a dent of change in the system that's not serving the population.
Dr. Privatera, about 40 seconds. I know you've said you're looking for volunteers. So
Right.
What do you want to leave with listeners?
Yeah, volunteering for taking the survey, and if you're interested in the Patient Clinician Alliance in any way, there's ways to reach us through the website. And just we hope this is a way of changing the system in our community for the better of both patients and clinicians, and psychological safety, so you can get ideas in without losing your job.
Okay. And Joel, final thoughts.
www.patientclinicianalliance.org.
PatientClinicianAlliance.org. I think I said .com earlier. It's .org. And the survey will link to it. They would love, to Dr. Cohen's point, they want everybody to take it. There's no limit to the number. The more people who take the survey, the more data and information they have on how to try to come forward with change recommendations. And when you're done, when you've wrapped it all up, come back here later this year. Let's talk about what you've learned. You want to do
Sounds
that?
good.
I'd love that.
You are all three. Let's book it. Come on back in the fall, and we'll find out where we're going next with this. I'm really grateful for the time. Joel Elliott, steering committee member for the Patient Clinician Alliance. Thank you for being here, Joel.
Great to be here.
Dr. Mary Cohen, lead of the Patient Survey Project, steering committee member for the Patient Clinician Alliance, a physician in private practice. I could go on. Dr. Cohen, thank you. Thank you very much. And Dr. Michael Privatera, founding member and steering committee member of the Patient Clinician Alliance. Thanks for your expertise as well.
Absolutely, Evan.
And from all of us at Connections, thanks for watching on YouTube. Thanks for listening to the program. We're back with you tomorrow on member-supported public media.
This program is a production of WXXI Public Radio. The views expressed do not necessarily represent those of this station, its staff, management, or underwriters. The broadcast is meant for the private use of our audience. Any rebroadcast or use in another medium without expressed written consent of WXXI is strictly prohibited. Connections with Evan Dawson is available as a podcast. Just click on the Connections link at WXXInews.org.